All right. Very beginning of the book, chapter 1. Go to page 5. Page 5. Very first page. Make sure you know what a certification is and a licensure. So know the difference between them. So certification is used to ensure all healthcare providers have at least the same basic level of knowledge. Licensure is the process by which states ensure the applicant are competent in the examination setting. So know the difference between the two. You might have to pick out which one's which. Left-hand side of the page, know what EMS stands for. Obviously, you doesn't. If you get that wrong, I'm going to come after you. Okay, real quick. Go to page 11. And I think you guys probably saw that once before. Know what the difference between an AEMT and an EMT. Remember, AEMTs can do supraglottic airways. EMTs cannot. 10-4?
That's good.
All right, let's move on to chapter 2. Okay, that's going to be page 51. Page 51. Left-hand side of the page on page 51. Kind of 2-3 sentences down to talk about partial immunity. Know what partial immunity is. Partial immunity protects against new infection. But germs that remain in the body from the first illness may still be able to cause the same disease again when the body is stressed or has some impairment in its immune system. So you know about partial immunity. Okay. And then page 53, obviously you guys knew about safety. Safety is the most important consideration at a hazmat. You guys would think might even had that one before. Turn the page to 54. Right-hand side of the page, there's some general guidelines when dealing with scenes involving hazardous materials. With 1, 2, 3, 4, 5, 6 bullets. Make sure you know those bullets when dealing with hazardous materials. So chapter 3. Okay, chapter 3. Go to page 85. We'll talk about consents. Remember your consents. Let's see, 85. All right, so you've got expressed, implied, involuntary, minors, and consent. So they're all kind of highlighted. I would go over all of those to make sure you know which ones are which. So when they describe it, you'll know if it's implied, expressed, involuntary, or minors. Go to page 93. Definitive signs of death. I would know those. 1, 2, 3. So defendant validity, rigor mortis, putrefaction. Know what all those are. If they describe it, you might want to have to be able to check it out. Those are all definitive signs of death. Not presumptive, but definitive. So know those both. All right, chapter 4, page 130. Left-hand side of the page, second paragraph. Remember that the report from form itself and all the information in it is considered a what? A confidential document. Everything in the report is considered a confidential document. Know how to correct your errors. Reporting errors on page 130. You put a line through it. Initial it. And then page 132. Documenting refusal of care. It's that first paragraph, last sentence, before the second paragraph, talks about If the patient refuses to sign, have a family member, police officer, or bystander sign the form verifying that the patient refused to sign. And then obviously, if nobody's there but your partner, who do you have sign? Your partner, right? We know that. All right. Step 5. Check 5. Okay, page 166. All right. Know what supraventricular tachycardia is. So put that word together. Supraventricular tachycardia. What is tachycardia?
Fast heart rate.
Yeah.
Very good. So supra meaning above, ventricle. So supraventricular tachycardia means obviously tachycardia is coming from above the ventricles. So
Atrium?
know all of your positions, prone and supine and left lateral and all that stuff, and know all of your words: lateral, medial, proximal, distal, superior, inferior, anterior, and posterior. Know all of those, which is on page 159. Left-hand side of the page is a picture. I would know that. Okay. And remember all those words I told you to circle that you needed to know: AED, AFib, BFib, centesis, ectomy, emesis, all that. Just make sure you remember all those, because you might see one or two of those. Chapter 6. Chapter 6 is going to be page 196. 196. Autonomic nervous system. Right-hand side of the page, the heart, down towards the bottom, second paragraph. The heart is an involuntary muscle. As such, it is under the control of the autonomic nervous system. Autonomic nervous system, remember that. What does that mean? What does that mean? Voluntary? Voluntary or involuntary?
Voluntary.
Very good. Okay. Know the circulation of blood, where it goes from right atrium, right ventricle, pulmonary arteries, back pulmonary veins into the left atrium, left ventricle, yada, yada. So know the flow of blood. Page 203. Know what the spleen does. I think you might have had one before. Filtering is the basic duty. Worn out blood cells, foreign substances, bacteria are removed from the blood. That's what the spleen does. Make sure you know what the spleen does. And on page 205, right-hand side of the page, second paragraph, it's talking about hydrostatic pressure. Know what hydrostatic pressure is. Fluid pushes against the vessel walls, force fluid out of capillaries. Number 43. Here. Kind of all over the place, so you guys bear with me. Go to page 207. 207. Right-hand side of the page, top of the page. Talking about the alpha adreneric receptors. See, it has alpha and beta. So if you look on the left-hand side of the page, it starts to talk about alpha and beta. But the alpha adreneric receptors are found in the blood vessels. When stimulated, the blood vessels constrict, thereby increasing blood pressure. So what controls the constriction of the blood pressure? Of the blood vessels? The alpha adreneric receptors. There's little receptors that are on the inside of the arteries and the veins. They're little teeny receptors. And when they're talking about adreneric, it's just related to the adrenal gland. So whenever uppy or you get freaked out or scared or whatever, norepinephrine or epinephrine,
shoots into your bloodstream, and inside the vessels, those little receptors pick up on the epinephrine and the norepinephrine, and then they cause the muscle to constrict. So that's what makes the artery constrict. And obviously, if we constrict our vessels, we're going to increase our blood pressure. So know that the alpha adrenal receptors are the ones that control that. 43, 52. Go to page. Go to page 192. 192 is here. 192, ventilation. All right, right-hand side of the page, you've got ventilation and you've got respiration. You better know the difference between the two. So ventilation is the mechanical part. Respiration is the gas exchange. Know the difference between them. All right. Good. There we go. All right, chapter 7. Go to page 252. 252. Boom. Okay. Elderly patients. Left-hand side of the page, bottom of the page, we're talking about the vascular system. When we get older, with increasing age, at the very bottom, the vascular system also becomes stiff. The diastolic pressure increases with age. So the vascular system becomes stiff and diastolic pressure increases with age. So which number is the diastolic? Top or bottom?
Top.
or
Bottom.
Bottom.
Very good. Do you remember that?
Bottoms.
Oh, I thought you said systolic.
Yeah. Oh, yeah. Diastolic is bottom. Left-hand side, page 249, right-hand side of the page, psychosocial changes at the bottom. In early adults, the first 3 words best describes the average human's world during this stage of life. It's work, family, and stress. Yep, you guys are pretty much there, right?
Which one was that again? Which page?
249, right-hand side of the page at the bottom. Work, stress, and family.
Got it. Thank you.
51. Sure, I do this here. Boom. Okay. Here. All right. Chapter 9, page 340. Oh, I'm sorry. Let's not forget 8. Go to page. Page 281, right-hand side of the page, about moving. There's 1, 2, 3, 4. There's 4 bullets right on the right-hand side of the page. You can pull on the clothing. You can place them on a blanket. You can rotate your arms. Place your arms on the patient's shoulders and through the armpits. So those are the 4 ways that you can move those patients. You can remember those. Now let's go to page 340. Chapter 9. Some have hardly any and a lot. Some chapters have a lot. So, page 340, left-hand side of the page, OPQRST. If they describe something, you should know, is it the O, the P, the Q, the R, the S, or the T? Better know those. All right, 81. All right, let's go to page 328. Same chapter. 328. Left-hand side of the page, top of the page. Positive pressure ventilation should be performed for patients who are what? Not breathing, or whose breathing is too slow or too shallow. Too slow, too shallow. You guys know who to add the patient. Remember, key terms: shallow, slow, not breathing, apneic, those type of words. Know when you've got to bag a patient. Page 331. Know your colors. You got your jaundice, your cyanosis, ashen. So left-hand side of the page, second paragraph, poor peripheral circulation will cause the skin to appear pale, white, or ashen. Read down a little bit more. It talks about the blood vessels appear blue or gray. That's cyanosis. Read down a little bit more. Liver disease or dysfunction causes jaundice. Know your colors. 99. All right. Page 340. Left-hand side of the page on 340. Palatating. Know what palatating factors are. So palatating is under P, which is provocation or palatation. Anything that alleviates pain. Does anything alleviate your pain? Or does anything make your pain feel better? That's provocation or palatation. Make sure you remember that word. And patient assessment. Keep going. All right. Page 347. It's a picture. Know those steps of patient assessment. First, you've got your scene size up and you're making sure you're safe. Then you're going to do your primary assessment, which is for what? It's to find any life-threatening injuries. Then you go down into your history taking. You do your assessment and then your reassessment. Make sure you know those steps. You need to know what DCAP stands for. I think one of you guys got that wrong with the instructor the other day. Okay, I know that. Okay, respiratory rate 354 at the bottom of the page, 1220. You guys should know that. Oh, actually, it's on 355. You got the table 9-3. Know the adult, school-age children 6 to 12, and infants. Know those three. So you got 12 to 20 for an adult, 18 to 30 for school-age children, and you've got 30 to 60 for infants. Know those numbers. Right. All right, went up to 10. Go to page 419. Okay, 419. Right hand side of the page, talk about different kinds of flow meters. You've got a pressure compensated flow meter. That's the one that has the floating ball. You guys usually see that in the truck when you're doing the truck. You got the little ball inside that thing. That's a pressure compensated flow meter. And then next paragraph it says the Bourdon gauge flow meter. It's not affected by gravity and can be used in any position. So if it's upside down, it's sideways, it's laying down, whatever. The Bourdon gauge flow meter is not affected. Go to page 427. 427. Left-hand side of the page. Kind of about a quarter of the way down to that paragraph on the left-hand side. Talking about positive pressure ventilation is initiated. More air is needed to achieve the same oxygenation and ventilatory effects of normal breathing. So during normal ventilation, the chest wall movement works similar to a pump. And then, however, when positive pressure ventilation is initiated, more air is needed to achieve the same oxygenation effects of normal breathing. So basically, if somebody's not breathing, they're going to need a little bit more pressure, air, with the BVM than you do with normal breathing. Make sure you highlight that and remember that. And then on the same page, actually, right-hand side of the page, words of wisdom, I would highlight that. So 5 to 6 for an adult, 3 to 5 for a child, 3 to 5 for an infant. None of those. 3. Go to page 405.
What page, Kevin?
405. On the right-hand side of the page, you guys should notice already, in an unconscious patient, the most common airway obstruction is what?
Tongue.
Patient's tongue. Left-hand side of the page, I think you already had this one, probably halfway through the paragraph. If your patient is found in the prone position, which means what? They're laying face down. He or she must be repositioned to allow for assessment of airway and breathing to begin. So obviously, if somebody needs CPR and they're prone, you can't do chest compressions with them laying on their face. Hello? Really? That's a question? All right. Here. Oh, this I don't need. What did I just say? Okay, go to page 395 and 396. 396. What do we talk about here? Right hand side of the page on 395. Bottom of the page, it's talking about oxygenation. Very bottom, ventilation without oxygenation can occur in places where oxygen levels in the breathing air have been depleted. Such as what? Turn the page, mines and confined spaces. So obviously you can be breathing, but are you getting oxygenated? Probably not. Not in a mine or in a confined spaces. Or if there's carbon monoxide in the air. So you can be ventilating, but you're not oxygenated. 397, time is critical. Know your minutes, especially your 6 to 10. That's when brain damage is likely. 6 to 10 minutes. All right. Chapter 11. Okay, chapter 11, page 457. You've got routes of administration. You better know those. It's table 11-1. I'm not going to go over them. You need to go over them. Page 458. Next page over. Know those routes with the on the right-hand side of the page. Know what intranasal is and an atomizing device is. So if you're going to go intranasal, you have to use a MAD device. So know what a MAD device is. Know your 5 R's. I don't know what page that is. You can't find it. You guys know your 5 R's though, right? You really need to try to find that page.
It's page 461. There's a table on the bottom.
Oh, there you go. Boom. Good job. And then there's those over-the-counter drugs. Where'd that go? OTC, they're called. Where's that? Oh, the metered dose inhalers. My bad. Okay, page, there it is. 475, right-hand side of the page. I think you might have had that one too. Common, on the right-hand side of the page, common prescription MDIs include metoprolol, which is Alupent or Metoprel, and albuterol, which is Provenol and Ventolin. So if you see any of those, know that they're an MDI. You better be able to pick that which one out, which one is an MDI out of the ones that they give you. All right. Chapter 12. Page 496. Four 96. There we go. Progression of shock at the very bottom. No compensated and decompensated. Now, pretty much remember, you're going to have all those signs and symptoms, but you're still going to have an okay blood pressure. You're compensating. The moment you start falling with absent peripheral pulses or blood pressure starts to fall, then you know you're in decompensated. So that's going to be your cutoff, where you know the difference between the two. Know your cap refill. Obviously, it's greater than what? How many seconds?
2.
2, it's bad, right? It's got to be under 2. Very good. All right. That's pretty much it. Page 501, you've got table 12-4. There's cardiogenic, obstructive, septic, neurogenic, anaphylactic. You turn the page, there's psychogenic and hypovolemic. So if they give you a definition of what type of shock, you're gonna have to be able to pick out which one it is, okay? You guys should be good with that. Page 516. 16. Page 517. Continue assessment by 762. All right. This is all CPR BS stuff, so I'm not going to go crazy with that. Obviously, if someone's unresponsive, the very first thing we do is check the pulse. We know that. Right-hand side of the page, second paragraph, although cardiac arrest in adults usually occurs before respiratory arrest, the reverse is true in infants and children. And why? Because they have strong hearts. Okay. Obviously, 13, right, 14, 15. 14, there's not a lot in 14. I think there's 2. 14, there's commission selection. Page 566, right-hand side of the page, right above reassessment. We're talking about end-tidal CO2. End-tidal CO2 monitoring should be considered in the patient if they complain of respiratory compromise. Now remember, you guys don't really do that. Only medics do. And then know how to reassess. Obviously, you're going to repeat the primary, reassess the chief. So number 1, you're going to repeat the primary assessment. Number 2, reassess the chief complaint. Obviously, 3, reassess ABCs, and do it every 5 to 15 minutes. That's all easy stuff. You guys should be okay with that. Know what drugs that we carry as far as EMTs. So as far as EMTs, we carry aspirin, oral glucose, and oxygen, obviously. And then we actually assist with nitroglycerin, albuterol, and EpiPens. So obviously we don't carry those. Know the ones that we carry, know the ones that we assist with. All right. 15. Yeah. All right. Chapter 15, 603. 603. Okay, right-hand side of the page, 603, bottom of that first paragraph. If the patient's breathing has inadequate depth or rate, it's too slow, ventilations may be needed to be assisted with a BVM. So if that's the case, ask yourself the following questions. 1, 2, and 3. You better know that. Ask yourself, is it going in? Is the chest rising? And is the rate adequate for my patients? All right. So, page. Cystic fibrosis 618. What does it do? Cystic fibrosis, what does it do? Well, it disrupts the normal function of cells that make up the sweat glands in the skin and that also line the lungs and the digestive and reproductive system. I would know that if I were you. All right, chapter 16. Go to page 664. All right, the bottom of the page. Cardiovascular emergencies.
Said 644, sorry.
Yes, 664.
664.
Left-hand side of the page, if you are en route, at the bottom of the page there, if you're en route with a conscious patient who has had a chest pain and then becomes unconscious, you need to take those following steps. 1, 2, and 3. Well, 4, 5, and 6. But obviously, if they become unconscious in our truck while we're driving to the hospital, we need to obviously check the pulse, stop the vehicle, and use the AED if we have to. Why do we stop the vehicle? Does anybody know?
Because they can't monitor while you're moving.
Boom. Very good. Make sure you remember that. That's part of the whole scenario process. All right. I go to page 648. 648. Okay. Obviously, before we ever give a drug, what do we do?
Draw.
All medical control. Left-hand side of the page, administering nitro. Second paragraph. After you obtain permission for medical control, if required, help the patient administer prescribed nitroglycerin. Can we give it more than once?
Up to 3 times.
Very good, but what do we have to do every time we go to give it?
Check the BP.
Right, and?
It's just all like above 100.
Right, but before we do it, what do we do?
Check the pain level.
Oh, call medical control.
Yeah, you have to do it every single time you do it. So you give it once, it's still not working. Now I got to call medical. Hey, can we give it again? Sure, give it again. Boom, it didn't work. The blood pressure's still good. Let's give it again. Well, we got to call again. You got to just keep bugging the doc every single time you do it. Don't forget that. All right. 71. Let's see. 85. Here. Go to page 631. Okay. Pacemaker. All right, we're talking about the pacemaker on the left-hand side of the page, down towards the bottom of the left-hand side. It's like that last paragraph. There's a stimulus that originates in the sinoatrial node. It's controlled by impulses from the brain, which arrive by way of the autonomic nervous system. So, that's where it originates. It originates in the sinoatrial node, and it's controlled by the autonomic nervous system. Remember that whole electrical portion of the heart? Kind of go back over that again. know about the electrical conduction. You know, it starts in the AV node and then it spreads down to the bundle of discs, that type of thing. But everything is controlled by the autonomic nervous system. We cannot control that. One more. Know your angina. Know what that is. It's 637, right hand side of the page. It doesn't always mean the person is having any mind. And for a brief time, the heart tissues are not getting enough oxygen. The pain is called angina. And can we treat that with nitro?
Yes.
Very good. Yes. Okay. All right. 17. Boom. All right, chapter 17, page 679. 679. We're talking about strokes. Aneurysm, right hand side of the page is 679. It's in bold down there at the bottom. Some people are born with a weakness in the walls of an artery. An aneurysm is a swelling or enlargement of the wall of the artery resulting from a defect in the arterial wall. Read down just a little teeny tiny bit more. The most notable symptom of a ruptured aneurysm is what? Oh my God, it's the worst headache I've ever had in my life. To know about an aneurysm and know the signs and symptoms. Know the two different types of stroke. If they describe it, you got to know which type it is. Is it an ischemic or is it a hemorrhagic? Left-hand side of the page, 678. Kind of halfway through the first paragraph. What you should be suspecting in a patient with a severe headache, seizures, and altered mental status. Early signs of ICP, which is what? Intracranial pressure, right? You need to know the early signs of intracranial pressure. Headache, vomiting, altered mental status, and seizures. 681. You guys should remember this, the conditions that mimic stroke. 1, 2, 3, there's 3 bullets there. Make sure you remember that. The next one is on page 686. Remember when they're talking about hypoglycemia and altered mental status? Left-hand side, kind of halfway through the first paragraph. Mental status is not likely to improve even after several minutes when someone's got hypoglycemia. So if they have a seizure, remember they're in that postictal stage, they eventually start to get better. But if you don't treat that hypoglycemia, that patient's not going to get better by not treating them. So know the difference between the two. Which one is which? I think that's it for this one. Oh, and the Cincinnati scale, where is that? Cincinnati Pre-Hospital. It's on 691. Know the three things we test: facial droop, arm drift, and speech. All right. And know the normal and abnormal responses to those. So it's kind of a scenario type based thing. So you need to know the signs and symptoms when you're doing your Cincinnati stroke scale. Right. Chapter 18. Moving right along. We're at page 712. But they're talking about infectious and non-infectious gastroenteritis. What is the primary symptom? Let's see. Gastroenteritis may be felt by non-infectious. Looks like it's like the third paragraph, right above diverticulitis, the last paragraph. The principal symptom in both infectious and non-infectious is diarrhea. Patients may experience large dumping type diarrhea or frequent small liquid stools. It may contain blood or pus, and it may have a foul odor. Ugh. All right, so that is your gastroenteritis. Make sure you know the signs and symptoms and what happens frequently. It's the principal symptom. The diverticulitis. And this is 18. Okay. Right hand side of the page, other organ systems on page 713. Next page over. Back pain is the common symptom when an aneurysm is starting to expand. Remember, it's that AAA. So what's the main sign and symptom for AAA? Oh my God, it's ripping and tearing, ripping and tearing. Remember those types of words that you start to see? It's a ripping, tearing sensation in their back. That's a AAA until somebody can prove it otherwise. That's one of those load and go type situations. 18. What's the urological thing? Southern urinary system. Kidneys. Chronic renal failure. There it is. Left hand side of the page, 713. Midway through, they're talking about renal failure. You've got acute and you have chronic. If they describe which one, you need to know which one's acute, which one is chronic. 19. Ooh, 19's got a lot. Okay. Step 19. What's the questions in 19 are out? Right, page 731. Okay, know what a Kussmaul's respirations are. Remember, we talked about the Kussmaul's with diabetics. When they've got hyperglycemia, it's on the right-hand side of the page at the bottom of 731. They're talking about Kussmaul's respiration. This respiratory pattern is the body's attempt to reduce the acid level by releasing more CO2 to the lungs. This breathing pattern is known as Kussmaul's. Usually that patient is pretty much unconscious in a coma state at that point. Their hyperglycemia is so bad it put them in a coma. They start to have that weird breathing pattern to blow off the CO2. That's a Kussmaul's. Let me see. Go to page 734. 734. Scene safety with diabetic patients. Evaluate your scene safety. And basically, they're talking about just be really careful with patients with hypoglycemia, because why?
They can be combative.
Yeah, they can go combative. And then don't just assume that they're drunk or they're this or that. Oh, you've got to make sure you check that sugar to rule out hypoglycemia and be very careful. If the patient starts to become super combative and start screaming and yelling, whatever, retreat, call PD, make sure you get the scene safe before you go back in. All right, we already know that. Go to page 730 again. That's 730. That's probably good. All right, right hand side of the page. You might have even kind of had this one before when we were talking about a new onset. Right hand side of the page down at the bottom with type 1 diabetes, a new onset. Patients with a new onset type 1 diabetes will have symptoms related to eating and drinking. So remember, anything poly is a lot. So urea, dyspnea, aphasia, weight loss, and fatigue. Make sure that you remember those, that's something that you would suspect in new onset type diabetes, somebody that's just getting it. They're going to pee a lot, they're going to drink a lot, they're going to eat a lot, and they're going to still have weight loss and obviously fatigue. Um, Just did that one. Go to page 734. 734. Here we go. Left hand side of the page, underneath all the bullets, we'll talk about hyperglycemia as a complex metabolic condition that usually develops over time and involves all the tissues of the body. But correcting this condition may take many hours in a well-controlled hospital setting. Now, hypoglycemia we can fix real fast. Hyperglycemia you can't. It could take days in a controlled setting, and you have to be in the hospital for that. Obviously, they got to get fluid in you. They got to get insulin in you, that type of thing. And then obviously know the signs and symptoms of each. Like if you have hot, dry skin, are you suspecting hypoglycemia or hyper?
Hyper.
Hyper, very good. So know those signs and symptoms. I think it's on page 730. There's that table, 19-1. So it's got the hyper versus the hypo. Go over those. Make sure you know the difference between the two. If they throw some stuff out there, you'll know which one it is, hypo or hyper. 88. Here. Go to page 738. 738. All right, right-hand side of the page, so giving oral glucose right underneath the glucose picture. If authorized by your system. Remember, if it's not authorized by your system, obviously you got to call medical control, but you still should call regardless. Excuse me. But if authorized by your system, you should administer to anybody that has 1, a decreased level of consciousness, 2, has a history of diabetes, and 3, the only contradiction is that they can't swallow, or they got such a severe AMS they can't follow commands. So those are those 3 things have to be in place in order to be able to give glucose, obviously with a permission. 735. 735. There's some bullets there on the right-hand side of the page under history taking. Know those bullets. So be sure to ask the following questions to a patient that has diabetes. There's those 4 bullets. 1, 2, 3, 4, actually 5 bullets. And make sure you know those 5 bullets. That's when obtaining a sample history from a diabetic patient. All right. All right, chapter 20. Oh boy, there's a lot in 20. What is 20? What is this? All right, just chapter 20, start. 20. Go to page 755. Delayed onset. Left-hand side of the page, common food allergies. With food, when we're talking about food, symptoms of a food allergy may take more than 30 minutes to appear. May not include the presence of skin, and may not include the presence of skin signs such as hives. So obviously, if somebody eats something, why does it take a little bit longer than everything else? Well, because it goes to the GI system, right? It has to get into the stomach and digest, and then start to flow through the blood. That's why that one is delayed in onset. The others are not delayed. Medications, plants, chemicals, insect bites, that type of thing, those are pretty quick. So the food is the one that's the delayed onset, and that's the reason, because it goes through the GI. And okay. page 762. Oops. Yeah, 762. EpiPen. There's 1, 2, 3, 4, 5 steps to giving an EpiPen. Make sure you go through those and know how to give an EpiPen. One, two, three. Page 753. Go back a little bit. 753. All right. You've got some highlighted words here. Go up towards the top. You've got an allergen. Any substance can become an allergen. However, some people do not experience allergic reactions the first time they're exposed to an allergen. So an allergen can be pretty much anything. That's what the person gets allergic to, is the allergen. So it could be a peanut, could be a bee sting, could be whatever. So know what an allergen is, and then obviously know what anaphylaxis is. So you've got the mild allergic reaction, itching, redness, and tenderness. And then obviously once we start talking respiratory or blood pressure problems, now we're in anaphylaxis. All right, and maybe step. Go to page 764. Again, know your dosage of your epi. Which one do we use to give an epi injection?
IM injector.
Yeah. What's the concentration?
1 to 1,000.
Very good. Make sure you remember that. Remember that it's 1 to 1,000. It's 0.3 milligrams. And obviously we don't go in the arm, right? We go in the mid lateral thigh. So the side of the thigh, 10 seconds, 0.3 milligrams for 1 to 1,000. Know all your stuff about your epi. All right, 38. $763. Okay, remember you had to go through those at 1 through 8. Make sure you know number 6 really well and you know number 8 really well. So record the time and dose of your injection as soon as you give it. And then if after 5 minutes it doesn't work, you can call medical control and give another dose. We already knew that too. All right, 38. That was it. That was good. 758. Page 758. All right. All right, so we're talking about BVM on the left-hand side of the page. The second paragraph, kind of the last sentence. We're talking about positive pressure ventilations. So on an unresponsive patient or someone with altered level of consciousness, the positive pressure ventilations you provide will force air beyond the swelling in the airway and into the lungs while you await more definitive treatment. So it's very important to do that. So upper airway swelling, your positive pressure ventilations will be forced through the swelling. So that's a good thing. Read down a little bit more in the second paragraph. Some patients in anaphylaxis may not present with severe respiratory problems, but primarily with signs and symptoms of circulatory distress, such as hypotension. So do you have to have the airway swelling and wheezing to be an anaphylaxis? No, you could just have a dump in your blood pressure. So remember, anaphylaxis is blood pressure and respiratory. Everything else is a mild or a moderate reaction, hives, swelling, that kind of thing. So know about the positive pressure ventilation. Okay. And then we go to 50s. Here. 761. Oh boy, let's see. Okay. Obviously, epinephrine table 20-2, you need to know all that. You need to know the indications, contraindications, actions, side effects, and typical dose. So obviously we know when to give it because they're having anaphylaxis. And then there's really no contraindication, obviously, if they're old and they have heart disease. But again, it's, the person still needs to live, so you still give it. And the action is the vasoconstriction and bronchodilation. And then obviously the headache, sweating, and then your dose is your 0.3 or your 0.15 for each. So know those, know that table, and you should be able to get 1 or 2 questions on that. And then, page 763. Symptoms improve because I've been other side effects. Okay. The side effects are on the right-hand side if you need to highlight it. So you got increased pulse rate, anxiety, cardiac dysrhythmias, pallor, dizziness, chest pain, headache, nausea, and vomiting. So obviously if you give somebody an EpiPen and their breathing starts to get better and their blood pressure is getting a little bit better, but they're starting to get real anxious, maybe their heart's beating too fast. Is that all normal stuff?
Yes.
Yeah, okay, so don't let that throw you. That's all just normal side effects of epinephrine. All right. Cool. Let's move on to 21. Toss this one out. Yeah. 755. 755. Wait, what? Oh. That can't be right. No, I guess so. No, that's in toxicology. That's not even the right thing. Oh, you know how sometimes they give me the wrong page number? This is going to be in toxicology in 21. But that's not the right page. So, okay, common names for activated charcoal. Right hand side of the page of 781. I found it. It's on 781, right hand side of the page. Right above the picture, there's some common trade names for activated charcoal, and they are Instachar, Actidose, and Liquichar. Make sure you remember those. Also, know what it's good for. If you read up above it, it's usually for pills. Remember, we talked about that. Pretty much pills. It's pretty much the only thing we use activated charcoal for. Activated charcoal is not indicated, nor will it be effective for patients who have ingested what? Alkali, poison, cyanide, ethanol, iron, lithium, methanol, acids, and organic solvents. So basically, look, we know that it's just basically for overdose of pills that they usually use it for. What are the side effects? Well, next page, 782, right above, left-hand side of the page, last paragraph, the side effects. Constipation and black stools. Number 44. 787. Pathomimetic. Signs and symptoms, the drug overdose, let's see. Oh, where it is. So pathomimetics. They're stimulants, so obviously you should know signs and symptoms of stimulants, right? Tachycardia, anxiety, that type of stuff. They feel good, produce paranoia.
They may also produce irritability, anxiety, fear, lack of concentration, or that kind of stuff.
Yeah. Where is that? I didn't get to highlight that one. Oh, I see it now. I see it.
Okay.
They also produce irritability, anxiety, fear, lack of concentration, and paranoia and delusions. Okay, got it. So, definitely tachycardia, irritability, anxiety, and fear. So, uppers. They're all uppers. Sympathomimetics are. Anything that mimics the sympathetic nervous system is what a sympathomimetic is. All right. 44. Page 745. Oh, they're going to do this to me again. That's not the right page. Okay. It's always this chapter. Know what substance abuse is. That's probably a definition word in the beginning. Abuse. Yeah, it's on page 771. Substance abuse is the misuse of any substance to produce the desired effect. Common complication of it is overdose. 75. Oh, again, it's not going to be the right page. Oh, we already went over that. That's the side effects of activated charcoal. Remember we talked about the constipation and black sleep. We already have that one. So whatever page that was. Okay, page 780. That one might be right. 780. Here we go. There's some bullets under history taking. That last one, it talks about how much does the patient weigh. If activated charcoal is indicated and permitted by local protocols, we will need to determine the dose based on the patient's weight. That's why we need to know how much the patient weighs. The antidote or neutralizing agent given by the emergency physician may be based on the patient's weight as well. So we got to know the weight of the patient when we're planning on giving activated charcoal because it's weight based. All right. Okay. Let's put that chapter. Okay. Chapter 22. Moving right along. How far do you guys want to go?
What?
The timing. How long do you want to go till?
We're about an hour in right now.
Want to do like 10 o'clock?
Yeah, that's fine by me.
That's like 50 more minutes? Or do you want, it's up to you guys.
That's fine with me.
All right.
The sooner you get it, the better. Yeah.
Okay, we'll go to 10 and see how we feel. Cool?
Yes, ma'am.
All right, rock and roll. Chapter 22. All right. Chapter 22. Let's go to page 817. All right, 817. Risk factors for suicide. It's a pretty much of a common sense thing. Remember we talked about people older than 40, particularly single, widowed, divorced, alcoholic, or depressed. Not married, so. Married males over 30. Alcohol and substance abuse, yeah, it's a common sense question, so know your risk factors for suicide. 29. Here. Go to page 805, talking about schizophrenia. 805. Know what organic brain syndrome is? Organic brain syndrome is temporary or permanent dysfunction of the brain caused by a disturbance in the physical or physiological function of the brain tissue.
What page was that? Sorry.
It's on page 805, left-hand side of the page. It's called OBS, or organic brain syndrome.
Thank you.
We all have organic brain syndrome.
Yeah, I would just say that. I think my friend Jeannie has it real bad. Okay, right-hand side of the page, functional disorder. What's an example of a functional disorder? Well, schizophrenia is a functional disorder that impairs bodily function when the body seems to be structurally normal. Something has gone wrong, but the root cause cannot be identified. So schizophrenia, obviously, and then anxiety and depression are good examples of functional, but schizophrenia mainly for your functional disorder. Quite a few on this one. I don't know why. That's 808. Left-hand side of the page, very last sentence, or very last paragraph, we talk about reflective listening. It's a technique frequently used by mental health professionals to gain insight into a patient's thinking. It involves repeating, in question form, what the patient has said. It encourages them to expand on their thoughts. So know what reflective listening is? (806), page prior. There's some guidelines for behavioral crisis. So make sure the scene's safe, know where your exits are, put your personal protective on, calmly identify yourself, and be prepared to spend extra time. It may take longer than normal to assess, listen to, and prepare the patient for transport. But then there's other little bullets there, but just make sure that you can kind of go over those safety guidelines for those types of emergencies. Final. All right. All right, page 804. Again. On that page before. Psychiatric emergency, right-hand side of the page. When a psychiatric emergency arises, patients may show agitation or violence or become a threat to themselves or others. Yeah. Psychiatric emergency. Yeah. Okay. Oh, I already had that one. Okay, so 804, right-hand side, psychiatric emergency. You know that. 4. Two of them here. Okay. 805. Okay. 807, scene size up. What's the main thing that, for scene size up with a behavioral crisis?
Make sure that we're safe, but they're not.
Man, these people are nuts. So make sure you have a scene, very safe scene, immediate law enforcement backup. If you're already there and things start to get out of retreat, and call for backup. Remember, again, safety, you see safety, that's going to be the answer. Page 70. 70. Page 815. 815. Talking about restraining a patient. Left-hand side of the page, right above the potentially violent patient, there's a little paragraph. Once a patient has been restrained, make sure you reassess the airway and breathing. Document this information in your patient care report. So again, make sure once you've restrained a patient that they have plenty of room, especially if you put a sheet or something over their chest or what have you. You always got to make sure you reassess the breathing so you don't injure the patient anymore. 98. 98, that's that one. Page 809. Right-hand side of the page, second paragraph. Let's second sentence down a little bit. What's your job? Your job is to diffuse and control the situation and safely transport your patient to the hospital. So your main job with psychiatric patients is to diffuse and control the situation. So then chapter 23. All right, 831. All right. Final. PID, pelvic inflammatory. Read down about kind of a quarter of the way down. It talks about the infection may then expand to the fallopian tube, producing scarring that can increase the risk of life-threatening ectopic pregnancy, eventually involving the ovaries. So that's the really bad thing about pelvic inflammatory disease, is that increases the risk of life-threatening ectopic pregnancy. Um, 11, yeah. So ovarian abscesses and ectopic pregnancies, if you don't treat your PID. All right.